Welcome to This Medical Life podcast. These are the stories of medicine with Steve Davis and Dr. Travis Brown. This is the story of soft tissue sarcoma, part 2. As we continue this series in sarcoma, we're hearing from a couple of our speakers how they've enjoyed hearing their colleagues talk, and it's not something that happens in the normal cut and thrust of life. So although we're producing this for GPs everywhere and medical students, there's also some peer-to-peer refreshing and stimulation that's coming from the conversations.
The amazing thing about medicine is when you think everyone above you, like when you're training, knows everything. And what you realize is people become specialized. You actually not forget other things, but sometimes you don't remember as much. And then they're doing their own specialty field. They're learning and going to conferences and learning the most up-to-date stuff, whereas you're doing the same thing. So actually the crossover sometimes is not much, and you discuss about patients. And that's what I was surprised about. You used to think that specialists being specialists would know everything. It's like, no, everyone knows their own little niche. And so it's actually quite nice to hear about what other people are doing. And that's why the motivation for this podcast, I'm talking to doctors, and I'll have either trained in it or, not even trained in it. I'll have gone to medical school in it. So it gets me up to date and learning. But sarcoma is one of those amazing things that it was pretty much, we could treat it into the mid-20th century with surgery. But it wasn't until very recently that we started getting extra treatments such as radiotherapy and chemotherapy. So this part is actually very new. And even the chemotherapy, when we're talking about sarcomas and just chemotherapy in general, has an amazing story behind it because it actually has its roots in chemical warfare.
Oh.
And so it wasn't until the 1800s when chemists were starting to experiment on all different compounds they came across something called sulfur mustard. And
the mustard gas. Is
mustard gas, that's right. And so chemists were actually experimenting in the 1800s and 19th century. And some of them noticed that, okay, this compound that they put together is vesicating. So it creates vesicles on people's skin. So the people who were probably most prominent in this area, the chemists, was Albert Niemann, who was a German chemist, and Frederick Guthrie, who was a British chemist. And they noticed this, it could be an ointment, it could be a gas, but it actually caused blisters on skin. And it was an irritant. And it had a bit of a pungent odor. Now, it sort of died down, but in World War I, the German military thought, well, what could we use with this? Well, what could it be doing? And they actually produced it turned out to be the first one they tried was chlorine gas in the second Battle of Ypres. And it actually worked amazingly well as a pretty offensive weapon against the enemy. Now, this is because people would die from this chlorine gas. And about a year later, they started producing a whole bunch of different gases, and one of them happened to be sulfur mustard. And this, again, was causing blisters, and it would cause an irritant to the eyes and mouth and respiratory tract. And it worked, unfortunately, in this matter, very well against that.
It's a very ghoulish part of human history.
It is. It's incredible. And because of the nature of this warfare that was, well, I mean, as illegal as anything is, the people at war, but war being war, people end up doing it. So armies became very interested in these chemical compositions. And what ended up happening was people started investigating, well, what are the compounds? And the United States in the 1930s actually came across nitrogen mustard. So this is, again, a different form of mustard gas. And it turned out to be a fair bit more systemically potent than the sulfur gas. But what happened from there was when they started experimenting, they found it was systemically worse. but it started to target things like lymphoid tissue and bone marrow and gastrointestinal tract. And so Yale University led a team by the person, Lewis Goodman, ended up running a team to start to experiment on, well, what does this actually do? And they were testing it on mice, and these mice had tumours. And when they exposed them to this nitrogen mustard, the tumours actually shrank. And so they had a radical idea of, well, what happens if we treat patients who have tumours with nitrogen mustard?
At this point, they lose their military funding.
Well, no, they still kept it. It was still kept research, and it was called Substance X or Compound X. And there was a 47-year-old patient by the name of JD who had huge lymph nodes in his neck because of most likely lymphoma. They called it lymphosarcoma, but we would call it lymphoma these days. And they were so large he couldn't turn his neck. He had failed all sorts of other treatments. And they said, would you be willing to try this experimental compound? And he said yes. And the remarkable thing is they gave it to him, and it dramatically reduced the size of the lymph nodes to a point of where they said they couldn't clinically find the lymph nodes anymore. And so
how was that administered?
Well, this is the experiment. It must have been systemic. So it must have been intravenous. They gave him this medication. And by itself, the problem is, though, the treatment worked, but it didn't take it away. It wasn't a curative treatment for the patient. It did come back. He ended up dying 5 months later, but we saw it as an avenue to be able to treat further patients. And they did treat certain patients. What they found, they treated patients with like leukemia, lymphosarcoma, again, lymphoma these days, and what they found was the best results was with Hodgkin's lymphoma. And so that was the most responsive to this type of, let's say, put it on quotes, chemotherapy. And so by the 1950s, they started to experiment, well, what drugs work well with different cancers? And so in the 1960s, we actually found one that was very useful against sarcoma. So this is the doxorubicin, which is still used to this day.
Which will be mentioned in the conversation.
Yeah, exactly. And this is where then in the 70s, we started to find out that combining radiotherapy also with everything, this adjuvant treatment, really affects patients and really affects the prognosis. And so this is where we are today. Chemotherapy is in, 8th, 9th decade. And so this is where we're starting to treat. We're treating better and targeted therapies, and even immunotherapy coming along, which is antibodies-directed chemotherapy type treatment. And so this is what we're looking at. So when you look at where we've come, which is just incredible line of treatment, but it is an evolving area, and one that we're just wanting to bring to doctors awareness, and particularly where to treat the patients, because these patients have better outcomes in specialist centres that treat sarcomas commonly. But again, we're just having a discussion with the specialists in this area and see what we can learn from them.
I'm never going to watch a World War I movie or documentary the same way again. You've just added more subtext to it. Professor Peter Grimison is a medical oncologist at the Chris O'Brien Lifehouse in Sydney. He's a visiting medical officer at the Royal Prince Alfred Hospital and clinical professor at the University of Sydney. Professor Grimison is involved in research, oncology health services, including rural oncology, as well as quality of life assessment in clinical trials. And Peter is a returning guest, and he's with us again today on This Medical Life podcast. Peter, welcome back.
Great to be back.
Peter, can you tell us about the stages of soft tissue sarcoma and what they mean?
The stages of soft tissue sarcoma are actually quite different to most other cancers. People will be familiar with the T&M system, and stage 1 and 2 generally means a cancer that's localized, so it's small in size, Locally advanced is typically a bigger tumour where, for example, it's spread to lymph nodes, and stage 4 is a metastatic cancer. So for soft tissue sarcoma, stage 4, again, is metastatic cancer, but everything else, it's completely backwards. And I think one of the drivers for that is, with very rare exceptions, sarcoma does not spread to lymph nodes. So that idea of stage 3 locally advanced being lymph node positive doesn't count. And then the other thing, you can have a tumour that's 20 centimetres in size, is enormous, and it's still considered a stage 1. So it's all back the front. And the real driver of stage in and of recurrence in soft tissue sarcoma is grade. So almost all grade 1 soft tissue sarcomas will be stage 1, and that could be an enormous, well-differentiated liposarcoma that's been there for years and sits quite dormant. Whereas you've got a small but very aggressive leiomyosarcoma or malignant peripheral nerve sheath tumour of nerves. And although it's relatively small, if it's high grade, it's aggressive, it's likely to come back, likely to metastasize, and that will be a stage 3.
So this is going to be a rather broad stroke, but how common is it for patients to present with stage 1, 2, 3 or 4? It
really depends, because there's so many different types of soft tissue sarcoma. We do see a lot of the benign or low-grade tumours, so distinguishing a benign fatty tumour or lipoma versus an atypical lipomatous tumour or a well-differentiated liposarcoma, they look pretty similar. You're just seeing fat. You use molecular tests like MDN2 to distinguish. But for those fatty tumours that are not aggressive, it's quite common for them to be large but never metastasize. Whereas for the aggressive tumours, unfortunately, it's very common at diagnosis to see metastatic disease. If we don't see metastatic disease, nevertheless, they're going to be high grade, and just by the presence of their grade, they're going to be at least a stage 3. We do learn in sarcomas to stage aggressively, as well as doing MRIs of the local area. We almost always do a high-resolution CT chest and a whole-body FDG PET scan looking for metastases. Most tumours, you focus on metastases, lung, liver, bone, but you do get soft tissue metastases elsewhere in sarcoma, and you actually have to ask nuclear medicine to literally do a full-body PET scan, so from the skull to the tips of the fingers to the toes. And a typical PET scan will ignore below the knees, below the shoulders, but you are going to miss metastatic disease to the soft tissue sites in the extremities.
So what's the important feature of determining if someone needs chemotherapy or not?
So it will depend on the situation. For localized cancers that can be removed, the role of chemotherapy is actually pretty small. We will discuss on an individual basis, but on average, trials for soft tissue sarcomas of the extremities have shown that the benefit of giving pretty toxic chemotherapy on top of surgery and radiation is maybe 3-5%. There is a group with a high risk of recurrence where it could be that the absolute benefit of chemotherapy could be 10%. So we may offer it in that situation, but only in small situations. We do see sarcomas of the retroperitoneum, for example, the inferior vena cava and the renal vessels. We commonly see leiomyosarcomas arising from the muscle of the veins. It sounds incredibly rare, and it is. In that situation, we're doing a trial where the chemotherapy helps, but it probably doesn't as a preventative treatment. We are developing other systemic treatments like immunotherapy for that. If the cancer's actually spread, we do offer chemotherapy, but there's some soft tissue sarcomas where chemotherapy works, but something like a well-differentiated liposarcoma or a slow-growing fatty tumour, chemo doesn't help, or a very aggressive sarcoma of nerves, malignant peripheral nerve sheath tumour. Again, these are inherently chemo-resistant. So, we consider the 99 soft tissue sarcoma subtypes, we consider the individual situation, the patient, and we really think hard whether chemotherapy will help or not.
Does the treatment change depending on the type, such as lipo or leiomyo, rhabdo, angiosarcoma?
It changes a huge amount. And I think the real lesson of this is if you don't get the diagnosis right, then you're going to be offering the wrong treatment. Any patient with a sarcoma, we strongly recommend they get reviewed in a sarcoma reference centre. It doesn't mean they need to have all their treatment there, but multidisciplinary team meeting, you've got 6 pathologists, you've got radiologists, you've got the clinical team, and just getting the diagnosis is right. Even just distinguishing sarcoma from melanoma from mesothelioma, they actually look very similar on microscopy. And a melanoma, in terms of systemic treatment, will be treated very differently to a sarcoma. And we've had many instances where very responsible colleagues from other hospitals have referred, and we've actually made a dramatic change to the diagnosis. But then even if we agree it's sarcoma, all those different types are treated completely differently. So a liposarcoma, a leiomyosarcoma, rhabdomyosarcoma, angiosarcoma, the treatments are all very, very different. In the old days, we used to do trials of chemotherapy where we just lumped them all together, and we didn't really get much signal of activity. But now we're getting smarter. We're looking at all these ultra-rare subtypes and doing trials for each, and we're actually getting more useful information. The challenge, if these tumours are incredibly rare, we need to collaborate nationally, internationally to try to get enough patients to answer the question.
Peter, I just want to take you back to when you were talking about chemotherapy and seemed to suggest not so much a trepidation, but a carefulness in when you go down that pathway. If you do, what are the common side effects of chemotherapy in this situation?
Yeah. I guess our biggest hesitation or trepidation is if you're giving chemotherapy as a preventative treatment for someone with a localized cancer, where you're trying to reduce the chance of it metastasizing. And in that situation, typically we would use combination chemotherapy with an anthracycline like doxorubicin, together with ifosfamide. That's a very potent combination. People, at least in our centre, will be in hospital for 3 nights. You've got to be cautious giving it as an outpatient. The typical side effects: fatigue, nausea, hair loss. Doxorubicin can cause cardiotoxicity, so we've got to monitor that very carefully. Ifosfamide can cause ifosfamide encephalopathy, which can be life-threatening. It can also cause hemorrhagic cystitis, where you get bleeding from the bladder. So these treatments need to be given in centres where people have experience administering the treatment, but importantly, selecting the patients. And if the benefit's only 5% and you're giving life-threatening treatment, that's a big worry for the patient. And it's also a big imposition on the health system. And if someone's over 60, if they've got heart disease, renal failure, I'd be very cautious doing treatments with a marginal benefit. I think in the metastatic setting, we can just do one drug at a time. The side effects tend to be less, and that's a different situation, but a lot of care given those possible side effects.
Are there any targeted therapies for sarcomas?
Yes, so there's lots more than there used to be. And now that we're routinely doing next generation sequencing, we can look at a tumour sequence for 400 or 600 different mutations, and we are getting better at doing that. And again, it depends on the situation. There was a recent trial for liposarcoma of something called CDK4/6 inhibitors, which have benefit. We have, if you're lucky, there's like a 1 in 100 chance of finding an NTRK mutation where there's an NTRK inhibitor. These trials are really hard. We were saying before that we're getting smart doing sarcomas in ultra-rare subtypes. So MDM2 inhibitors look really promising for liposarcomas, which are MDM2 positive on molecular sequencing. And a company actually developed a MDM2 inhibitor, but then based on the FDA recommendation, their phase 3 trial was against a very good comparator, and the trial read out negative, and they actually abandoned the development of an MDM2 inhibitor because it wasn't as good as first-line chemotherapy. Well, we would say, fine, but for second or third line, this would be a really good drug. And so the community of trying to be advocating, how can we rescue this particular drug? It's just so disappointing when you get a signal in a rare subtype and then there's commercial or regulatory barriers to making it available to patients.
Now, you've mentioned some of the side effects in acute setting. Is there possible long-term side effects that doctors should know about?
So there can be. I think, one of the really sad things about soft tissue sarcomas is that for many people, the prognosis is not prolonged. But for example, anthracyclines like doxorubicin can cause long-term cardiotoxicity. Sometimes you can get long-term bone marrow suppression, but not a lot else. It would be different, for example, for bone sarcomas like osteosarcoma, where our chemotherapy is actually incredibly effective. As a curative thing, the absolute benefit of adding chemotherapy to surgery in osteosarcoma is 60%. So the cure rate goes from 20% with surgery to 80% with surgery plus chemotherapy. And these are younger people who have enormous benefit from chemotherapy, but they can have long-term cardiotoxicity, neuropathy, tinnitus, hearing loss, slight increase in second malignancy, and so on. So the bone sarcomas in the younger patients are more of a concern, but the benefit is huge and the risk of long-term side effects is much smaller. So for most people, it's still worthwhile.
Is there any immunotherapy agents out there or on the horizon?
Well, it's coming through, and you may be aware that on the PBS in Australia now, you can use immunotherapy for any advanced or metastatic cancer that's deemed to be immunotherapy sensitive. So suddenly the sarcoma community have the opportunity to use immunotherapy, and we've really got to decide what is an immunotherapy sensitive cancer. Now, if it's lung cancer or melanoma, there's enormous phase 3 trials showing a benefit. But for all these ultra rare sarcoma subtypes, there's not a lot of evidence. So we need to decide if on a small phase 2 trial, is it worthwhile? But we contributed to a international trial of adding immunotherapy to radiation before surgery as curative soft tissue sarcoma. Australia contributed the largest number of patients internationally, and we showed that for particular types of soft tissue sarcoma, UPS, and so on, that immunotherapy did reduce the chance of recurrence. We're wanting to verify that in a phase 3 trial. There are some ultra-rare sarcomas like alveolar soft tissue sarcoma where it can work. But I think broadly speaking, immunotherapy for cancer seems to work best for cancers where there's an environmental trigger that has caused a high tumor mutation burden within the cancer. So people smoke, get lung cancer, people get sun exposure, get melanoma, people get bladder or kidney cancer due to toxins going through the bladder and kidney. So those cancers, immunotherapy works. And then in the sarcoma space, sarcomas of the skin, like a cutaneous angiosarcoma or a Kaposi's sarcoma, those cutaneous sarcomas seem to be most likely to respond to immunotherapy, whereas the other soft tissue sarcomas less so. And then the bone sarcomas like osteosarcoma, which we're not talking about today, immunotherapy doesn't seem to help at all. So we're trying to get a better sense. Actually, the Australian New Zealand Sarcoma Association is going to be doing a national study led by one of my fellows at Chris O'Brien Lifehouse to actually collect prospective data. So maybe we can come back to you in a year and tell you where immunotherapy really does work.
Looking at the patient's progression, how do you assess your treatment goals for patients going through treatment?
Yeah, so in that curative setting where we very rarely offer preventative chemotherapy, it's really just do the treatment and then monitor closely for recurrence. In the metastatic setting, it's the usual things any oncologist does. So noting if symptoms of cancer are improving, if a palpable lump's getting smaller, doing regular imaging. We again spoke about just doing a standard CT scan may not be enough, doing a full body PET scan right down to the toes and the fingers, and seeing if there is a response to treatment. In truth, in soft tissue sarcoma, we tend not to see a dramatic shrinkage to chemotherapy, with some rare exceptions, but that's what we would monitor for. We're doing a study in Australia, liaising with the University of Michigan, trying to get early signals of response. It's not good for a patient to have a toxic chemotherapy to find out 4 or 5 months later it's not working. So we're actually looking at liquid biopsy, so doing circulating DNA to measure the levels of sarcoma in the bloodstream, and maybe we can get an early readout after just 6 weeks and say, listen, the chemo's working, keep going, or it's not, switch. Now, measuring circulating DNA is hard in sarcoma. I spoke before about testes cancer. It's all serum microRNA 371. Soft tissue sarcoma, there's going to be thousands of different mutations. So it's a feasibility study to see if it's going to help.
I have not heard much about sarcoma. So if I was sitting in front of you, I wouldn't know as a patient what questions I would ask you. I don't know where I'd start. What are some of the common questions you get with patients?
So I think you get all the common questions. What's my prognosis is probably the biggest one. What are my treatment options? Most patients in most cancers want to have surgery just to get it out as quickly as possible. In sarcoma, where you realize that might be surgery, worst case, it could be an amputation or loss of function, that you're not able to walk, or very invasive abdominal surgery like a pelvic exenteration. You might actually say, is there an alternative? What are all the systemic treatment options? But there is so much variability in a patient's willingness to undergo very toxic treatment for what could be a small or a large benefit. So it's often as much me asking them, well, what are your priorities? What are you willing to go through? What are your expectations? I had a patient I saw recently with a very rare tumour, epithelial hemangioendothelioma. He had these enormous masses in his liver and lung, and it was feared there was going to be a very, very aggressive malignancy. But after a very big multidisciplinary discussion, careful review of scans, I said, this actually looks very indolent. It's probably been there for years. We can probably just watch it. And getting a patient to understand that simply watching things is okay is a big thing. But then what I say to the patients is, and it's easy because they've already come and seen me, but hopefully other patients are aware as well, coming to a sarcoma reference centre to get a proper diagnosis, a proper management plan is really important. And again, you can go back to your local centre to have ongoing treatment. But if you've got the diagnosis wrong or the treatment plan wrong, then you're not going to have as good outcomes.
I must say I would have pushed back on saying just watch it. There is something inside us that we want a prescription or we want surgery. I guess that is part of what it is to be in medicine this day, is to understand that negotiation and education.
People think you're mad. You've got these massive things. We're just going to do nothing about it. So it's a long discussion, and it's not just a one-off, but it's on multiple occasions. If the person comes in by themselves, it's like, listen, go home, read about it, think about it, and please bring your partner or family or trusted friend next time. You want to have time and support. Talk to our sarcoma nurse. We can offer for you to talk to other patients. Don't rush to make a decision. And I often say, I know you want something done yesterday, but if you invest 3 weeks now to make the very best decision on the best information, that's, could change what happens over the next 20 or 30 years. So that thoroughness and pause for thought is really important.
I'm not sure if you're looking at 5-year survival is relevant in sarcoma, because we typically use stage 1, 2, and 3, but you said actually grade is more important. How do you measure, is it still 5-year survival using stages, or is it more the grade?
Well, we use this cute app on our phones called a Sarculator, a sarcoma calculator, and that's developed by a very very good group in Milan, in Italy, who lead a lot of sarcoma research. Now we collaborate with them very strongly and contribute. But we put in all that information. So we put in the size of the tumor, we put in the grade, we put in the type of tumor. Is it aggressive? Is it not aggressive? We put in the location. That will give us a 5-10 year overall survival risk of relapse. The other really interesting thing, and this is validated by this group in Milan, you actually put where did the patient have the treatment done? Did they have it at a sarcoma reference centre, or did they have it at a low volume or non-sarcoma reference centre? And that piece of information may change the 5-year survival by 10% or more. So it's a very nuanced outcome for 5-year survival based on all those factors. But if you've got a well-differentiated liposarcoma that's indolent, hopefully it's been removed, it certainly could come back in the same place, but very unlikely to metastasize. If you've got a malignant peripheral nerve sheath tumor or a high-grade angiosarcoma, even though it might have been small, you're going to watch it like a hawk. You might be seeing them every 3 months for 2 years, every 6 months for another 3 years, annually after that, because unfortunately these often come back, often early, but sometimes very late as well. Yeah, but we can individualize that outcome for the tumor in the patient.
Are there any signs during treatment that are either particularly good or particularly bad prognostic signs?
Obviously, if the tumor is responding to treatment, that's going to be a much more positive sign. If someone undergoes surgery and they can have a complete resection, that's going to be a much more positive sign. Whereas if the tumor is progressing or there's positive margins or disease left behind, that's much more concerning. The ability of the patient to tolerate the treatment is a big thing as well. We spoke before about, toxic combination, doxorubicin, ifosfamide. You've got to be very careful to select patients. And so for patients not able to tolerate treatment, that's going to be much more concerning. But again, we have to have very nuanced discussions. You might have someone in their 80s or even 90s. And I just have to have an honest discussion and say, I think chemotherapy's got a high risk of shortening your life expectancy. I don't think it's going to be the right thing. We do have some gentle options, something like oral cyclophosphamide chemotherapy or modified liposomal doxorubicin or perhaps immunotherapy. But someone in their late 80s or 90s, I really do worry that the risk of side effects is going to outweigh any benefit. And although, as you say, people want to have some treatment, sometimes a long discussion as to why that is not the right thing will be in their interest.
I'm deeply appreciating the levels of nuance in this field of sarcoma. That's really coming through in this series that we're doing. On that note, though, are there any final thoughts or advice you have for doctors or even patients about soft tissue sarcomas?
I think it's just coming back to that idea of getting an expert assessment from a sarcoma reference centre to get the diagnosis right. If someone's having local treatment, such as surgery, make sure that it's done right the first time. I know you've covered in previous podcasts that if you have a whoops lesion and you have a whoops surgery, people may not do as well. I think to remain hopeful, some of sarcomas are very aggressive, where sadly the outcomes are poorer, but there's a huge amount of interest and development that's going on. There's a large number of trials. Patients are understandably frustrated that big commercial pharma may not have a huge interest, but there still are a number of niche pharma companies who can see that if they can develop a treatment for a niche and they can have worldwide access, that can be in their interest, and obviously that's in patients' interest as well. But also drug repurposing, we can access many different types of chemotherapy targeted drugs. We published a trial last year with the US of a drug called eribulin, which we use in breast cancer, which happened to work incredibly well for angiosarcoma and epithelioid hemangioendothelioma. So people shouldn't feel that there's not interest. People shouldn't feel there's not drug development, because we're definitely making better progress. And the more patients are willing to participate in research and trials, the more advances we're going to make.
Professor Peter Grimison, thank you again for returning to This Medical Life.
It's a pleasure. Thanks very much.
Associate Professor Stephen Thompson is a senior staff specialist radiation oncologist and chair of the soft tissue sarcoma multidisciplinary team at the Prince of Wales Hospital's Naloon Comprehensive Cancer Centre in Sydney. He's a conjoint associate professor at UNSW and is on several state and national cancer scientific advisory committees. Steve enjoys seeing patients, research, teaching, and also life outside medicine. Goodness me. He listens to lots of podcasts, but has never before been on one. I'm sorry this is your first experience, Steve, but welcome to This Medical Life podcast.
Thank you for asking me to join you, and I hope I don't perform abysmally.
We'll see. If people get to hear this, then you haven't. Okay. Steve, what is the process that a patient goes through to have radiotherapy?
This is something I could talk about for hours, so please stop me after a few minutes. What I should say is, as a medical student, a few years ago, we had absolutely no exposure to radiotherapy, and so I knew nothing about it really until I joined the program. So I'll go to the beginning. I guess basically I'll often first hear about a patient in a multidisciplinary team meeting. If it sounds appropriate for them to probably have radiotherapy, I'll meet them in my new patient clinic. At that clinic, they'll first be usually assessed by the registrar, who'll do the usual doctor thing, history, examination, investigations, present the patient to me. We use it as a learning thing where we go through the results together, decide what sort of treatment they should have, if any extra tests need to be done. Then the registrar will go on to the next new patient, and I'll go and join Mr. or Mrs. Jones and often check a few things, maybe examine the mass, and then talk about the treatment. And then the next step is for them to be booked for a radiotherapy planning or simulation session. At that session, they come back to the cancer centre, lots of people talk to them, and essentially they have a CAT scan, but it's done under our supervision, and we get them to lie down in what's very importantly a comfortable, stable and reproducible position, because that's the position they're going to lie in for each radiation treatment. We do the scan, they go home, and then myself and the team spend a few days or a week working on the radiotherapy plan, which is essentially the process of working out how to focus the radiation on the sarcoma and the area around the sarcoma that might be harbouring microscopic disease. Once that's all ready, and it's a sort of back and forwards process between myself and the radiotherapist, make it a bit warmer here or a bit cooler there. Anyway, once it's ready, it goes through a lot of QA. Then the patient comes back for their treatment. And in a curative course of sarcoma radiotherapy, that can be anywhere from 2 weeks to 5, 6 or 7 weeks of daily treatments, Monday to Friday. The treatment itself only takes a few minutes, but by the time the patient comes in, waits their turn, lies down on the treatment machine, which is called a linear accelerator, has the treatment and goes home, they're with us for about half an hour per day. The machine rotates around the patient, focusing the radiation into the mass. Essentially, because it's X-rays, they don't see it, they don't feel it, doesn't hurt, doesn't burn. Every week, they'll be scheduled to see myself or my registrar. We try and alternate, and that's called a treatment review, and that's to check for toxicity, make sure things are going okay. And I should say, before each actual treatment is delivered, the linear accelerator does a mini CAT scan to check that we're targeting the area accurately. Anyway, once the treatment finishes, we see them in follow-up while those acute toxicities settle. They'll often be booked for surgery 4 to 6 weeks later. Maybe after that, they'll get chemotherapy, and then they'll go into a follow-up program. And that really summarises the whole process in hopefully not too many minutes.
Now, from memory and just scanning across it, you also make, is it masks, or you actually have people to put in a position to stay in that position? Does that happen often, like with regards to like legs as well, being able to do it? Or are you able to reassess that each time they come in?
Yeah, so there's a lot of things we do at the planning session, and I warn the patients that this is going to take longer than the other scans you've done, because we have to get them into that position that's stable and reproducible. So in the case of my head and neck colleagues, they have what's called a thermoplastic mask. So it's a mask that they heat up and it molds to the head and holds the head nice and still, has holes for the eyes and the mouth. In the case of sarcomas, which are often on the limbs, we often have them lying on a device called a vac bag, which, if you can picture lying on a bean bag, maybe not quite like that at home in front of a TV, but it's like a bean bag. It molds to the shape of a body, and then you suck the air out. And then it forms a sort of comfortable but stable platform for that limb or for the body. And it's not just me doing this. There'll be myself, my registrar, but really importantly, there are radiotherapists who are like, I guess, the radonc version of a radiographer. And they're the ones who run the machines, do the planning session, press the buttons on the computers. You wouldn't want me doing that.
How much back and forth is there between you and the patient during this? Because this seems like they're in a very much more engaged mode with you in this course of treatment than in some places where we're either knocked out or we just sit there quietly while something happens in the other room.
Yeah, so the only ones who are knocked out are those very, very young patients treated by my paediatric colleagues, and I'm very grateful I don't have to treat those patients. There is a lot of backwards and forwards, particularly not just at the consultation when we're chatting, but also at the planning session, because the worst thing that can happen is you get them in a position that's too artificial, it's uncomfortable for them, it's obviously going to be bad for them if they're going through weeks of radiotherapy in a position that hurts them, but it's also not going to be stable, and therefore it's not going to be accurate. So we go to a lot of effort getting that just right. I don't just treat sarcomas. So, for example, I treat rectal cancers. And in that situation, the setup is very standardized. You're treating the pelvis, you have a patient lying there. I do come to the planning sessions, but it's not 100% necessary because essentially they're having a scan, it's all protocolized. Whereas a sarcoma, it might be on the foot, it might be on the shin, it might be on the shoulder, it could be any part of the body. And often it's very helpful for me if I have a senior radiotherapist with me, because often there's a bit of a chat about, well, what do you think about this position? What about that position? Often we try this, we try that until we get it right.
So what features are important when you're considering if someone needs radiotherapy or not?
Okay, so this can be a short answer or a long answer. I'll try a medium answer. So I guess probably the mainstay we have to emphasize, go back a step. So when I first hear about a patient and meet a patient, the sort of thing that we're taught to think about is patient tumor and treatment factors. So, that 40-year-old with a localized extremity sarcoma is going to be very different to the 97-year-old with dementia in a nursing home with lung metastases. And that leads to the next thought, is this going to be someone who should have radiotherapy or not? And if they should have radiotherapy, is it a curative or palliative pathway? For argument's sake, let's think of the classical situation, which is an extremity soft tissue sarcoma. It's a sarcoma on the arm or the leg. That's localized and it's a curable situation. The mainstay of treatment, please don't tell any surgeons out there I'm going to say this, but the mainstay of treatment is actually the surgery. And a long time ago, in fact, it was an amputation. So this is well before my time, up until the 1970s. I've got a few grey hairs, but not that many. And obviously, no one likes an amputation. And in the US, they did a randomized trial comparing amputation versus wide local excision and adjuvant radiation treatment. They had a lot of trouble getting patients to agree to that. They only got 43 patients on the trial. But they showed there was no difference in survival, in cure rate. So that led to the current standard of care, which is more limited surgery and then radiation to mop up what the surgeons had maybe left behind. So when we sort of discuss this patient in MDT, we hear about the situation, we look at the scans, and there are some sarcomas that are adequately managed with surgery alone. And a classic example would be a superficial one that's just under the skin, in the subcutaneous fat. It's low grade, it's not too big, less than 5 centimeters, and the surgeon's confident they can get a well-clear margin. Now, in that situation, the local control will be well and truly above 90% with surgery alone, and they don't need radiotherapy. Most other situations with surgery alone, the local control is not going to be that high, and we would typically be adding radiotherapy. And that can be given adjuvantly after the operation. That's commonly done in some other centres in Australia. Here and in many centres in Australia, we prefer what's called neoadjuvant radiotherapy, where we give the radiation before the operation. There are a few red flags that make us cautious about radiotherapy. Things like some patients with connective tissue disorders can have more severe toxicities. And if someone has had prior radiotherapy, to some extent the body, if I can put it this way, remembers the radiation it's had. And if you have to re-irradiate, you can cause more toxicities. So we're cautious in that situation. It doesn't mean they can't have radiation, but we have to be a bit more, even more careful than we would be otherwise. I hope that answers the question.
Just in palliative scenarios, will patients just been, is it surgery, adjuvant, or in that area?
Overall, a radiation oncologist work, about half of it is palliative radiotherapy. And the classic example is metastatic bony disease. 5 fractions of radiotherapy will improve pain in about 70 to 80% of patients. Sarcomas don't generally go to bone. They can, but that would be quite uncommon. And the classic palliative situation in a sarcoma is someone who has, at presentation, they've got the primary mass, but they've got multiple lung metastases, for example, or they're too elderly, too frail, and the mass is technically inoperable. In the first situation, maybe they'll start with palliative chemotherapy, but if something is causing a problem, the mass is causing pain, something like that, you can give a short course of palliative radiotherapy to try and deal with the pain. And the main difference between a palliative and a radical course is in the palliative setting, you're trying to make the radiation less of a problem than the disease. So you're trying to make it effective but have less side effects than the problem the disease is causing. Whereas in the curative situation, you're happy to go through many weeks of treatment in the endeavour to get rid of a malignancy.
Does the amount of radiation vary for different types of sarcomas? So you've got liposarcoma, leiomyosarcoma, rhabdomyosarcoma, or angiosarcoma. Does the radiation dose change?
So I shouldn't simplify what I do and make me sound oversimple, because my medical oncology colleagues will laugh at me, but they do already, so that's okay. Essentially, probably the main thing that determines how and how much radiation we give is actually whether it's preoperative or postoperative. And there's a beautiful randomized trial that was done in Canada a couple of decades ago, showing that in the preoperative setting for extremity sarcomas, we need to give 50 gray in 25 fractions. So a fraction is a treatment over 5 weeks. And in a postoperative setting, we have to give more. We have to give 66 gray over a longer period of time. In my own practice, instead of just doing that 50 gray in 25 fractions, we have a specific protocol where we give some chemotherapy beforehand as a radiosensitizer to make the sarcoma more sensitive to the radiation. And then we give 30 gray in 20 fractions BD over 2 weeks. So we do the treatment much more quickly. We get more bang for our buck, so to speak, and it appears to cause less side effects while being equally effective. There are some situations where we would alter how we do it. So, for example, there's a type of sarcoma called a myxoid liposarcoma, which I really like treating. And the reason for that is whereas most soft tissue sarcomas don't actually shrink down with radiotherapy, they just kind of look the same when they have their completion operation, whereas a myxoid liposarcoma shrinks down really nicely. And there's now some very recent published data showing that with a lower amount of radiation, you can get close to 100% local control with surgery. So that's really pleasing. And then you have all sorts of other sarcomas, and this is the whole issue. There's over 100 different types. So Ewing sarcoma will have its own dose and fractionation that's optimal. Rhabdomyosarcomas, the pediatric ones all have their own ones. So the short answer is it depends.
You mentioned at the beginning that there are some sarcomas that surgery alone can deal with, especially superficial ones. And
Yep.
You hinted then there's possibly some cases where radiotherapy gets you almost to the end of the road, but is there always the need for that last surgical step?
Yeah. So as a general principle in radiation oncology, in the curative treatment of malignancies, you can give definitive radiotherapy instead of surgery. So, for example, for anal cancer, I give curative chemoradiation in an organ-preserving procedure. And that's because anal cancers tend to be very radiosensitive, and the patient gets to keep their bottom in the vast majority of cases. In the case of soft tissue sarcomas, they're somewhat radiosensitive, but not exquisitely radiosensitive. And although you can control them with radiation, the best chance of cure is with combined modality therapy. Occasionally, you will get a patient who has a technically inoperable tumour, and there's more and more data accumulating that with very high doses of radiation, you can control them, but it's not the preferred pathway if it can be resected. And I have to emphasise, and probably other speakers will have said this, in sarcoma, it's all about optimizing not just cure, but also function. You know, you can cure anyone by cutting off a leg and irradiating the whole body and giving them super doses of chemo, but you kill the patient. So in our setting, what we're trying to do is get rid of a lump, but also optimize for long-term functional outcome in that limb. And that's usually by surgery and radiotherapy, but not always. I had a patient a couple of years ago who had a large mass in her supraclavicular fossa, intimately involved with the brachial plexus. Now, surgery with that would have left her with a useless arm, and it would have left her with positive margins anyway. So I gave her definitive radiotherapy. I saw her recently. It's about 2.5 years down the track, and the mass has shrunk to just some firmness in the SCF. There's no evidence of activity. She's doing really well, and she'll hopefully be cured. But as I think we all know with cancer, only time will tell.
Well, what are the common important side effects for patients?
So in radiotherapy, we divide those into short-term and long-term side effects. And this is part of a whole discussion I have with a patient when I first meet up with him, and I write things down as we go along. Patients often record things on the phone, and it's great if they bring family members because extra pairs of ears are better than one pair. In the short term, when they're having a treatment, usually initially no side effects, but as time passes, inflammation builds up in the irradiated area. And that's what leads to the side effects. So the side effects really depend on where you're treating, in the same way that I guess you wouldn't say the side effect of an appendicectomy is different to a tonsillectomy. So typically they will get a skin reaction where the skin becomes first dry, then a bit pink, and then perhaps a little red. The lump itself may get a bit edematous and may become a little bit uncomfortable, although pain is very uncommon. Often they'll get very tired. Usually the side effects generally are fairly mild. A difference would be if you have a sarcoma that is close to the skin, and rather than focusing the radiation inside, you're having to focus the radiation on the skin as well, particularly if you've got one with actual cutaneous involvement. And in that situation, you bring the dose up to the skin surface, and by the end of a course of treatment, particularly if you're doing the adjuvant treatment after the operation, so the bigger radiation dose, then you can get what we call moist desquamation, so that by the end of a treatment, the skin is red and peeling. It often looks a lot more painful than it is. It's usually not particularly painful, but it can be quite itchy, and sometimes it hurts. And then you have specific situations. So, the patient with a sarcoma in the groin, I find challenging to treat, and patients find challenging to have that treatment, because you get some radiation on the genitalia, and particularly, a sarcoma at the base of the penis, that can be a very tough treatment to go through. The other classic situation is a sarcoma involving the hand or the feet, and they typically get a very brisk reaction on the hand. These things are temporary, though, and the important thing to say is that the radiotherapy reaction peaks towards the end of the treatment, and it settles down over a few weeks afterwards, by which time, of course, the patient is getting ready for their operation. The other sort of situation is the retroperitoneal sarcomas, which we sometimes irradiate, and so they'll get some exit dose in the abdomen, and so they can have anorexia and nausea. That's usually controllable with prophylactic antiemetics, and they can also get bowel disturbance. Generally, I'll say, compared to some of my other patients with the GI malignancies, generally the patients get through this in a better way. And what's really surprising about sarcomas is it's quite unusual for a sarcoma itself to be causing a lot of pain. You can get a patient with a 15 or 20 centimetre mass in the quadriceps, and it's just sort of a bit uncomfortable.
Is there any medical emergencies that doctors should know about for patients who are receiving radiotherapy, like a tumour lysis syndrome or anything?
Yeah, so I wish that sarcomas were so sensitive that we got tumour lysis syndrome, but unfortunately or unfortunately, we don't. Look, overall, compared to with the situation with my med-onc colleagues where, patients can get neutropenic sepsis and all that sort of thing, problems like that are very uncommon with radiotherapy. I guess one thing to say is not to mix up a radiotherapy skin reaction for cellulitis. So obviously cellulitis, antibiotics, radiotherapy skin reaction, you don't need antibiotics. Sometimes I guess the other thing to say is the side effects generally build up slowly. So you usually don't have a situation where a patient's well one moment and, a few hours later desperately unwell. So there's not a lot of really severe problems to watch out for, but there can be just general build-up in problems where you get the skin reaction. They're getting more and more tired. They're getting fatigued. Patients often need a lot of emotional support. They may need social support. They may not be able to work during the treatment. And because the treatment's going on for a period of some weeks to 6 weeks, 8 weeks, or et cetera, that can be an issue for many patients. Of course, a patient with a malignancy can get any of the malignancy-associated problems, so they are at risk of DVTs, at risk of pain. Patients with metastatic disease are at risk of the problems that those can cause. And a classic rad-onc emergency is malignant spinal cord compression, but that's much more common from the malignancies that go to bones, like breast, prostate, etc., rather than sarcoma.
What are some of the common questions that patients ask you when they're going through this?
I apologise for the cliche, but all patients are different, and you've got the patient who has 1,000 questions, you've got the patient who has no questions, you've got a patient who knows nothing about radiotherapy or sarcomas, and you've got the patient whose every single relative is a doctor and they've been all over the internet, and now AI has put in its 10 cents worth, and everything in between. It may be correct, it may not be, and their neighbour had radiotherapy for a lung cancer 50 years ago, and look what happened to them. So I guess as part of my sitting down with them, I have a process where I go, and I think most of my colleagues do this as well, I have a process where I explain what the disease is, what a sarcoma is, where it is. I explain why they need a radiotherapy and what the radiotherapy involves, a little bit like what we've discussed today. And then at the end of a consultation, and usually my consultations are an hour, and of course I usually end up running very late, and then we have a chat. Any questions? And often it's sort of practical questions about, what about work, or do I need time off, or am I going to be radioactive, which you're not, and things like that. And, I give them my card, my email address. Sometimes I get an email later the day about this or something. And then when they come back for the planning session, we often reiterate things and reinforce things because, as we all know, you can spend a lot of time talking to someone and only a small proportion of that information, myself included, will be retained.
One question about long-term side effects that doctors should know about. Is there anything that doctors should flag that this patient's had radiotherapy? I need to think about this long-term.
All cancer situations, long-term toxicities are a big issue, potentially, particularly for sarcoma, where we're trying to optimize, like I said, cure and function. So after the treatment is finished, I'll be coming into clinic, often alternating between myself and the surgeon for follow-up. We also have a survivorship centre here at Prince of Wales, and many of the cancer centres are exploring things like this where they can see a medical oncologist who's got an interest in survivorship and long-term function. Specific radiotherapy-related things include that the skin can be a little bit darker or look a bit different. The tissues under the skin can be a bit firmer or a bit fibrotic. And again, that very much depends how much radiation they've had. With the neoadjuvant OLBA protocol I talked about, that typically doesn't occur, but with adjuvant radiotherapy to a much bigger dose, you certainly do see those changes. There can be joint stiffness, some weakness, some edema peripheral to where the sarcoma was treated. Probably in my experience, and we do have data on this, the main thing that really impacts on function, though, is really how much muscle is going to be removed. So if you have a small sarcoma and a small muscle that has to remove, function will be good. If the patient is going to lose their entire quadriceps, or they've got something down on a nerve and are going to lose an important nerve, that's where you get a big effect on function. While saying that, the reconstructive surgeons can do amazing things, and your other speakers probably talked about this with transferring tendons and things like that. And I suppose I should say there are very rare long-term complications of radiation that have to be mentioned. So there is a risk of bone fractures in field. I've never seen one of those in my practice, but it occurs. And probably the most feared thing is second malignancies. And that risk is proportional or inversely proportional to age. And in fact, what's probably less known is most sarcoma patients are quite elderly, and their risk of radiotherapy related to second malignancies is very, very low.
Stephen, just finally, any final thoughts or advice about radiation oncology in soft tissue sarcomas?
I think probably the most important thing to say is that, and again, your other speakers have probably said it, but no problems reinforcing it, these are rare tumours. Their management is subspecialised, and so ideally they get referred into a sarcoma unit where we have surgeons, radoncs, medoncs, pathologists, radiologists, the whole team who are experienced in treating these, and we can put our multidisciplinary hats on and hopefully get the best outcomes for our patients.
Associate Professor Stephen Thompson, thank you for being part of This Medical Life.
Yeah, thanks for asking me. I've enjoyed it. I hope you've all found it interesting.
This Medical Life is recorded in the Talked About Marketing Studios in Adelaide. For show notes and more information about the podcast, visit thismedicallife.com.au. You can contact the hosts on social media. Dr. Travis Brown can be found on X. His username is @Dr. Travis Brown. That's Dr. Travis Brown. And Steve Davis can be found on LinkedIn. Go to linkedin.com/in/TheRealSteveDavis. This has been a PathNotes Proprietary Limited production.